So hemostasis is a process which involves platelets, clotting factors, and endothelium. So these are the very important three components of this process of hemostasis that occurs at the site of vascular injury and culminates in the formation of a blood clot, which will prevent the further extent of the bleeding. So immediately what happens, immediately just after the vascular injury, there is arteriolar vasoconstriction which occurs immediately, and it is mediated by reflex neurogenic mechanisms such as the endothelin, but this is transient. Next comes the process of primary hemostasis, which means there is formation of a platelet plug here, and then the process of secondary hemostasis comes into play where there is deposition of fibrin. Now primary hemostasis may the endothelium exposes the von Willebrand factor and the collagen, which will promote the platelet adherence and activation. Activation of the platelets will change its shape from round to flat with spiky protrusion. That is the activation of the platelets, and then it will release the secretory granules, and that will ultimately cause platelet aggregation, which will form the primary hemostatic plug. Now this process I will deal in details in a few minutes. And then comes the process of secondary hemostasis, where there is deposition of fibrin because the vascular injury will expose the tissue factor, and the tissue factor will now bind and activate the factor 7, and then that will ultimately cause the thrombin generation. Thrombin will cleave the circulating fibrinogen into insoluble fibrin, creating a fibrin meshwork, which is a potent activator of platelets, leading to platelet aggregation. So thrombin is ultimately giving rise to platelet aggregation, and then this process is known as secondary hemostasis, which will ultimately consolidate the initial platelet plug that is formed. Next, there will be clot stabilization and resorption. This polymerized fibrin and a platelet will aggregate. It will undergo contraction to form a solid permanent plug that will prevent further hemorrhage. This counter-regulatory mechanisms like the tissue plasminogen activator will ultimately limit this process of clotting, and that will eventually lead to clot resorption and tissue repair. Now, very important, there is a question that comes that what is the function of the endothelial cells in the process of hemostasis? So, all these points that I'm going to discuss is important for that answer. So, it should be emphasized that endothelial cells are the central regulator of hemostasis. So that is why you get this question, because endothelial cells are the central regulators of hemostasis. The balance between the antithrombic and the prothrombic activities of endothelium determines whether thrombus formation, propagation, and dissolution will occur. Please remember that normal endothelial cell is having anticoagulant properties. It does not really cause coagulation. It expresses anticoagulant factors which inhibit platelet aggregation and coagulation, and it will promote fibrinolysis. But after injury, this endothelium will now acquire this procoagulant activities, means now it is ultimately giving rise to some factors which will cause the coagulation process. So basically, platelets play a very important role in the hemostasis by forming the primary platelet plug, which initially seals the vascular defect, and it provides a surface which will bind and concentrate the activated coagulation factors. अभी alpha granules में क्या है that you have to know. It has the molecule p-selectin, and it also contains the proteins which is involved in coagulation, like the fibrinogen, coagulation factor 5, von Willebrand factor, etc. Along with that, it also has fibronectin, platelet factor 4, and platelet derived growth factor and transforming growth factor. And the dense or the delta granules contain the ADP, ATP, and ionized calcium, serotonin, and epinephrine. These points can be asked for your Viva questions. Now coming to the process that is explained in detail here, that how exactly does this primary platelet plug is formed. So first there is platelet adhesion, followed by platelet activation, and then we have platelet aggregation. This process of platelet activation involves this change in shape of the platelets along with the secretory functions. So you can see that these two events is often referred to as platelet activation. So which are the two events? Number one, the platelet changing the shape, and number two, the release action or the secretion of the platelets. These two events together is called platelet activation. So first we have platelet adhesion, then activation, and then aggregation, and then ultimately the plug is formed. So platelet adhesion में क्या हो रहा है? You can see that the platelet surface has a receptor which is glycoprotein 1b, and that is ultimately going to bind with von Willebrand factor. The platelets also adhere to the exposed collagen by the platelet collagen receptor, which is the glycoprotein 1a or 2a, right? And after they are getting bound by each other, the platelet will change its shape to spiky sea urchins, which will increase the surface area. Now the platelets are having a spiky surface, and now this conformational change will happen in the glycoprotein 2b3a, which will increase its affinity for fibrinogen, and ultimately there's going to be a release action or secretion of the granules. This thrombin will activate the platelets through a special G protein coupled receptor, which is called as the protease activated receptors. Now this process of platelet activation and ADP release will stimulate further platelet activation, which is known as recruitment. So this process is kind of having a positive feedback, and then this ADP will bind to this G protein coupled receptor. Now the process of platelet aggregation will come into play. This conformational change in the glycoprotein 2b3a that occurs with the platelet activation will now allow the binding of the fibrinogen that will form a bridge between the adjacent platelets. If this is the platelet and this is the platelet, now this will be kind of joined to each other to form a fibrin meshwork. So all these are platelets, and now they are getting bound to each other by this fibrinogen, which will ultimately cause this platelet plug. Also, you must know that there is concurrent activation of thrombin, which will stabilize the platelet plug by causing further platelet activation and aggregation. Thrombin also converts the fibrinogen into insoluble fibrin, which will cement the platelets in place, creating a definite secondary hemostatic plug. So from the platelet plug, now this thrombin will create a meshwork of fibrin, which will ultimately stabilize and cement this entire platelet plug formation to give rise to a much stronger secondary hemostatic plug. Now coming to the disorders which are associated, if you talk about the von Willebrand factor, the deficiency of VWD will cause the von Willebrand disease. The deficiency of this GP2B3A will cause Glanzmann thrombasthenia, and GP1B will cause Bernard-Solier syndrome. Now, if we talk about this very important point, and that is prothrombin time is increased when there is problem in the extrinsic pathway. And which are the factors which are involved in the extrinsic pathway? It is 2, 5, 7, and 10. Out of which you just remember 5, 7, and 10, because 2 is common in both of these pathways, right? So just remember 5, 7, and 10. These are the factors involved in the extrinsic pathway because of which the PT is increased, and the factors which are there in the intrinsic pathway, because of this the APTT will increase. There's another question which comes: what is the function of thrombin? And these are the points that you need to focus on. So what happens is that thrombin's action is that it converts the fibrinogen into a cross-linked fibrin. So this thrombin will convert the soluble fibrinogen into fibrin monomers, which will polymerize into an insoluble fibrin, which will amplify the coagulation process. It stabilizes the hemostatic plug by activating factor 13. Okay. Next point is that the thrombin is a potent inducer of platelet activation and aggregation through its ability to activate the PAR1, which we have just read before, thereby linking a platelet function to coagulation. It also has got pro-inflammatory effects and as well as anticoagulant effects. So ultimately there will be a fibrinolysis through enzymatic activity of the plasmin, which will break down this fibrin, and there will be dissolution of this plug, and ultimately the coagulation process will get limited. This is basically what happens normally. Now, this is a very important question, as I mentioned before, that what is the function of the endothelium? So, the balance between the anticoagulant and procoagulant activities of endothelium often determines whether clot formation, propagation, and dissolution will occur. If injured or exposed to pro-inflammatory factors, endothelial cells lose many of their antithrombotic properties and they ultimately cause thrombosis. So therefore, the endothelium has got the antithrombotic properties as well as the prothrombotic properties as well. So if you just talk about the antithrombotic properties, we have the platelet inhibitory effect, anticoagulant effect, and the fibrinolytic effect, right? So all these 3 points are important. Endothelium releases a number of factors which inhibit the platelet activation and aggregation. Among the most important are the prostacyclin, nitric oxide, and ADP. Similarly, the anticoagulant effect also is present because the endothelium will shield the coagulation factors from the tissue factor in the vessel wall and expresses multiple factors that actively oppose the coagulation, most notably the thrombomodulin, endothelial protein C receptor, heparin-like molecules, and the tissue factor pathway inhibitor. So you can see here that basically this fibrin, once it get degraded, we have this fibrin degradation products or the D dimers, which is used as a clinical marker for the thrombotic states. Now coming to the hemorrhagic disorders, we know that there are defects in the primary hemostasis, which means in the platelet defects or the von Willebrand disease, because of which you have a small bleeds or petechiae or purpura. You do not have hematrosis or bleeding in the joints. You just have petechiae and purpura, and mucosal bleeding may be associated. And this is what is happening in the von Willebrand disease, which is because of a defect in the primary hemostasis process. Now, a complication is that there can be thrombocytopenia. Now, the defect in the secondary hemostasis process, which means in the coagulation factor defects, you have bleeding in the joints, which is hematosis. Very, very important point. You don't get this when there is a defect in the primary hemostasis. And if you have generalized defect including the small vessels, then you have palpable purpura and ecchymosis. Okay. So now coming to the important point, which is the thrombosis. How does the thrombosis happen? You know that there is a Virchow triad in thrombosis, in which you have endothelial injury, because endothelial integrity is the most important factor to maintain this, and therefore endothelial injury will give rise to thrombosis. Along with that, there will be abnormal blood flow and hypercoagulability. So all these 3 important points are there in this triad, which is the Virchow triad, because of which there is thrombosis. Thrombosis is basically because of endothelial injury, stasis or turbulent blood flow, and hypercoagulability of the blood, which is known as the Virchow triad. So now we want to read each of them in detail. Endothelial injury, you know all these points I've already explained, and now it's just a brush up. So endothelial injury will lead to platelet activation, almost underlying the thrombus formation in the heart and the arterial vessels, right? This severe endothelial injury will expose the von Willebrand factor and the tissue factor, and that will ultimately give rise to a prothrombotic state, as I mentioned earlier, how the platelets are getting activated and how there is basically formation of the platelet plug. So this process is called as endothelial activation or endothelial dysfunction. Because of this endothelial dysfunction, this is ultimately getting converted into a prothrombotic state. So basically endothelium, normal conditions may they have antithrombotic or anticoagulant properties, but whenever there's any kind of injury, then the endothelium is having now the prothrombotic or the procoagulant properties. So what are the procoagulant changes happening? The endothelial cells will be activated by the cytokines, which will downregulate the expression of thrombomodulin, because thrombomodulin has got thrombin activity, right? So therefore ultimately the pro-inflammatory action of thrombin is getting exaggerated, because of which there is procoagulant changes, and also because of the anti-fibrinolytic effects, ultimately there is coagulation. Next is that there's going to be alteration of the blood flow and hypercoagulability. All these factors will ultimately cause coagulation. This chart is important, just go through it. These are the hypercoagulable states basically. Now if you talk about something which is known as the HIT or the heparin induced thrombocytopenia, you can see that basically the activated platelet will release something called as the PF4. This PF4, once it is getting released, this will ultimately bind with the heparin to form a complex, and now this complex will stimulate the B cell to release antibodies, and now this entire complex complex along with the platelet, complete entire complex will now get phagocytes by the macrophages. This is how the entire platelet is getting destroyed, because ultimately the macrophage is phagocyting these platelets which are bound to these factors, and these factors consist of heparin and PF4. This will also cause platelet activation and platelet aggregation, which will also lead to thrombosis. So thrombocytopenia and thrombosis will be happening side by side. Now I'll be taking you directly to the chapter of bleeding disorders, in which I'm going to explain and link to you. So basically what is happening in the bleeding disorders is that bleeding disorders can be because of a vessel wall abnormality. Number two, it can be because of a reduced platelet number. You can understand, right, that if the platelets is decreasing, then there's bleeding disorder. If the vessel wall abnormalities is present, then there's bleeding disorders. And if the platelet function is defective, then there's bleeding disorders. So bleeding disorders can be classified into these three categories. And now, what are the disorders under each of these categories? If we talk about the vessel wall abnormalities, it can be caused by infection, drug reactions, scurvy, and ED syndrome or Henoch-Schönlein purpura. And if we talk about the thrombocytopenic conditions, this is the chart where you can see that all these points are mentioned regarding the decreased production of platelets and the decreased survival of the platelets, right? There can be immunologic destruction. Along with that, there can be sequestration of the platelets or dilution by transfusion. The chronic ITP and the acute ITP. So acute is mainly found in the children. You know, this is a self-limiting viral condition, right? And the glucocorticoids are given if there is thrombocytopenia. But what about the chronic ITP? The autoantibodies are directed against the platelet membrane glycoprotein, which is the 2B3A or 1B9, which can be demonstrated. And therefore, ultimately, these platelets are getting reduced, which is leading to thrombocytopenia. The marrow will show megakaryocyte, right, because of the compensatory increase in the megakaryocyte in the bone marrow. Petechial bleeds will be present. The peripheral blood will show abnormally large platelets. You know, these platelets will not be functional. These are megathrombocytes. This chart is also important. Thrombotic macroangiopathy. You know, there's a condition called the TTP where you have deficiency of the ADAMTS, and then you have the hemolytic uremic syndrome. And now coming to the third limb, which is about the defective platelet function, you have two disorders, which is Bernard-Solier syndrome and Glanzmann thrombasthenia. Right, this point is important, that in Bernard-Solier syndrome there is no aggregation with ristocetin. This is a very important Neet PG wale question, that there is no aggregation with ristocetin. There is normal aggregation with other agonists like ADP, collagen, epinephrine. Very important. Okay, now in Bernard-Solier syndrome you get giant platelets and there is deficiency of 1B9. This giant platelets is a very important exam question, but this is not present in the Glanzmann thrombasthenia. In Glanzmann thrombasthenia, there is no aggregation with ADP, collagen, or epinephrine. So all these agonists, you know, there is normal aggregation in Bernard-Solier, but in Glanzmann thrombasthenia, there is no aggregation. Rather, the ristocetin aggregation is normal here. Okay, so both of this is just the opposite of each other. In GT, you have a normal aggregation. In BS, you have a no aggregation with ristocetin, and giant platelets is found in the BS syndrome. A very important question. So here I mentioned the same thing that I have told you previously, that prothrombin time is increased when there's a defect in the extrinsic and the common pathway, and the APTT is increased when there's a defect in the intrinsic and the common pathway. And therefore, if you talk about the coagulation defects, then if you see the hemophilia A, because in hemophilia A you have the deficiency of factor 8, and now you see factor 8 is present in the intrinsic pathway, and therefore the PT is normal but the APTT is increased. And in hemophilia B you have deficiency of factor 9, and similarly here also the PT is normal and the APTT is increased because 9 is coming under intrinsic pathway, right? So therefore the APTT is affected here. If you talk about the von Willebrand disease, the APTT is affected here because von Willebrand factor forms the complex with the factor 8. Okay, you can see here that this is a complex which the von Willebrand factor is forming with factor 8, which ultimately activates the factor 10. The factor 8 is being stabilized by the von Willebrand factor, and therefore factor 8 is again coming under intrinsic pathway, and therefore the APTT is affected in cases of von Willebrand disease. So if we talk about each of these diseases in detail, we know that the von Willebrand disease will present with spontaneous bleeding from the mucous membrane, excessive bleeding from the wounds, and this is an autosomal dominant disorder. There are three types. The type 1 and 3 is associated with a quantitative defect, okay, and type 2 is associated with a qualitative defect, a very important exam question. The patients with the VWD have defects in the platelet function despite having normal platelet count. So platelet count is normal here, but the function is defective. Now, because a deficiency of VWF decreases the stability of factor 8, therefore type 1 and type 3 are associated with the prolonged APTT. If we talk about the hemophilia B, then yes, it is an X-linked recessive trait, again a very important point, and here there is deficiency of the factor 9. The DIC, this is an acute, subacute or chronic thrombohemorrhagic disorder which is characterized by excessive activation of coagulation and the formation of thrombi. So this is a very dangerous kind of a situation where there is formation of a thrombi in all the microvasculature, which ultimately causes death of the patient by tissue hypoxia and infarction. The most important effect of tissue factor or factor 7 is activation of factor 9, which in turn activates factor 10. Now, activation of factor 10 will lead to generation of thrombin, which is the central player in clotting. At the site where the endothelium is disrupted, the thrombin converts fibrinogen to fibrin, stimulates fibrin cross-linking, inhibits fibrinolysis, and activate platelet, all of which augment the formation of a clot. So ultimately there is formation of a clot. And now this clot will get deposited in several microvasculature, giving rise to so many symptoms. So here you can see that because of this massive tissue destruction, or because in the obstetric complications and because of the sepsis, there is a release of tissue factor which cause widespread microvascular thrombosis, because of which there is venous occlusion leading to ischemic tissue damage, activation of plasmin which causes fibrinolysis, and now there is inhibition of the thrombin platelet aggregation, which will again lead to bleeding, and there's a lot of consumption of the clotting factors, and therefore in the blood you will see all the clotting factors and the coagulation factors will decrease. You can see that there can be microangiopathic hemolytic anemia, dyspnea, cyanosis, respiratory failure, convulsion, coma, acute renal failure. By this I want to end this chapter. I hope you enjoyed watching this video. If you like my content, then please consider subscribing. I will meet you very soon in my next video. Till then, take care, keep studying, and thank you for watching.